Hello and welcome to virtual event 4 of the 6th International Symposium on Intrauterine Devices and Systems for Women's Health. I'm Rachel Farad. I'm the event coordinator for the entire series. And on behalf of the organizing committee, I am pleased to introduce Mitch Crennan, who will be the moderator for the first panel.
Hi, good day, everyone, whether you're morning or afternoon, and thank you for joining us. It's great to see the list where we have truly an international group of attendees, which is one of the benefits, I think, of Zoom, at least for now. Sorry, we can't all be together. This is our faculty for today. I'm going to be the moderator for the first half of the session, and Dr. Jill Long will then take over and moderate the second half of the session. I'm really excited about what we have in store for you. If we can go to the next slide, as we go to talking much more about, in the first half of today, level 1 type of evidence about IUD provision that helps inform not only what we do clinically, but a lot of other research that goes on to look at real life use of IUDs. And then the second half, I'll let Jill introduce that when that comes along with, again, just an amazing panel of speakers. If we go to the next slide. The learning objectives, this is just so that we can be sure that we make it clear to everyone. And today we're going to be describing level 1 evidence, going over some studies as well as evidence about non-contraceptive use and the evidence for and against expanding use of IUDs and IUSs beyond contraception. If we can go on to the next slide. The talks today are all accredited for continuing medical education credit, and those of you that are seeking credit must complete a course evaluation that will be distributed at the end of the webinar. Please go on. Here are the disclosures for the faculty. You can see that many of us work with many companies, and I think I always like to say that if we are working with many, then we are biased by none. We'll move on. I'd like to thank the coordinating committee. This has been a hard talk to put together, a symposium to put together, as we know, because of the COVID epidemic, but the just coordinating committee deserves great applause for making sure that sessions that were supposed to be in person have been translated in a way that we can all attend from wherever we are over the course of the year. And Anita is part of the team today, and bravo to everybody. Lastly, the symposium organizers would like to acknowledge that a symposium like this can't always move forward without generous support from educational grants as well as the sponsors that are listed here. So with that in mind, we're going to move right into the sessions, and I have the pleasure of first introducing Dr. Cynthia Harper, who is a professor of obstetrics, gynecology, and reproductive sciences at the Bixby Center at the University of California, San Francisco. She is director of the UCSF Kaiser Permanente Mentored Scholar Training Program, known to many of us as BIRCH program, which is Building Interdisciplinary Research Careers in Women's Health. So Cynthia, thank you for being here today.
Thank you so much, Dr. Crennan, and thanks to all of you for being here for our symposium. Next slide. I am talking about the work of our program at UCSF that does research and training in contraception, and our research program is a really important building block of our training program. So I'm going to talk a little bit about how our randomized trial and the level 1 evidence grew through implementation science into a healthcare provider training program. Next slide, please. Okay, randomized trials. They have, everyone knows about the randomized trial and how important that is for changing clinical practice and contributing to the science, but there really is a lot that goes on before and after the randomized trial. Nobody has just conducted a randomized trial and avoid, well, maybe that actually has happened, but a lot of times if you're going to do a large randomized trial, it requires a lot of resources, a lot of collaborators and partners, and take certain steps to build up to that point where you have an intervention that you would like to test. So just to talk a little bit about what went into the randomized trial that we ran. We conducted first a lot of formative research with almost 100, I think, in-depth interviews with providers to assess gaps in contraceptive clinical practice. And the interview stage is really important because it allows things to come out that we as researchers hadn't thought of, and that may be much more important than the topics we were originally interested in. And we, in our in-depth interviews, found out that counseling really varied on contraceptive methods, and a lot of people, when they counseled patients, were including certain methods tend to include the pill pretty universally in counseling, but there were a lot of methods that weren't really mentioned or were only mentioned in the case. And for IUDs, for example, they were generally mentioned as a niche method for older women coming in at the end of childbearing, and really other patients weren't really hearing about it. So after in-depth interviews, we also conducted a series of national probability surveys, which means random sampling, so that we would have generalizable data on these clinical practice gaps that we were noticing. And I'll just mention, we built on the work of Dr. Nancy Stanwood. I think was the first one who had conducted a survey looking particularly at the practices for IUDs among providers, and who knew what and who was providing what. We did surveys among family practice physicians as well as OB/GYN physicians. And then we also did national probability surveys among nurse practitioners who have a lot to do with contraceptive care in the United States. And what we found was relatively low knowledge and skills about IUDs and primary care. And there were high skills in the OB/GYN care, but there was still this very restricted ideas of patient eligibility with, at this point when we were conducting these studies, adolescents, nulliparous patients, a lot of women just weren't even hearing about these methods and didn't know about them. We also noted in abortion care practices and primary care, there were certain ways with clinic flow and stocking of devices and cost issues and reimbursement reasons why the IUD and the implant weren't being mentioned in counseling or weren't being offered. Cost issues were really prominent. So with this information and also looking at all of the really exciting work going on in the field, and at this point the large observational trial that had to do with IUDs and implants was a choice project coming out of WashU and led by Dr. Pipert and others, and they were seeing in an observational trial that if they were to include IUDs and implants in a structured counseling script and with no cost methods, that a lot of people coming into their clinics were in fact interested in using the method. So we, looking at the existing studies and the literature and our formative research, we developed and piloted a provider training intervention that involved the full clinic staff. We thought it was really important for health educators to be on the same page as the clinicians and involve them all in our training intervention, which was delivered as a UCSF CME accredited course, where we hope to change clinical practice change and in turn to improve patient outcomes. Next slide, please. So the study design that we chose was a cluster randomized trial, and I'm going to stop here for 1 minute because it differs from RCT in a couple fundamental ways that allowed us to test what we wanted to test in a really great way. And you do with cluster trials, you do follow the guidelines, but there are specific extensions to trials that you adhere to in reporting, and also in the design and thinking about the trial, there's certain differences. Next. So how is a cluster design different? Well, what they're really great for is when you have an educational intervention that is being delivered to a group, like to a, in our case, a clinic, but also in educational research to a classroom. When you have individuals within a larger group and a larger group. And I became familiar with them from global research and HIV research. Cluster trials were being used where certain testing interventions were being given in various geographic regions of a country. And it was a really great way to see across wide swaths what is happening. Whereas a randomized trial is the scope of it is generally smaller and more controlled and more restricted. This cluster trials tend to be close to pragmatic trials where they kind of reflect more real world and real clinic conditions. So your flow chart has two levels because you're looking at your cluster, and in our case, this is the clinic site was a cluster, and eligibility had two levels too, whether a clinic site was eligible, and then whether the individual patient coming into the clinic was eligible to enroll as a participant. In designing it, this sample size calculation really has to account for the correlation between patients in the same clinic and providers in the same clinic. And this is done through taking into account something called the coefficient of intercluster correlation. And the number of clinic sites or clusters you have. More, please turn on your mute.
Cancelei a Michelle faz tempo já.
Thank you.
Ela veio amanhã para passar roupa.
Please turn on your mute, Ilsa Maria. Thank you. For example, each individual joining the trial doesn't give as much information as they do in an individualized randomized trial because they are correlated with others in their clinic. So you have to get a lot of different clinic sites to be in the trial to have sufficient power. You then use analyses that account for the cluster design, and outcomes you can look at the individual level, or you can look at the cluster level, or both. And we actually looked at both. Next slide, please. So the cluster randomized trial that we conducted with Planned Parenthood Federation of America, and that was really great to do it within one agency in the health centers of Planned Parenthood, because that allowed us to be able to recruit a sufficient number of clusters or health centers, that's really the big challenge of a cluster trial is how are you going to get enough of your clusters to participate. And we're really appreciative to Johanna Morfesis and Dr. Carolyn Westhoff, who helped us to run this trial. Here is the article that with the main findings from the trial, and I'll mention my colleagues and co-authors. It took a big team to run this trial: Dr. Corrine Rocca, Kirsten Thompson, Johanna Morfesis, Dr. Suzanne Goodman, Dr. Philip Darney, Dr. Carolyn Westhoff, and Dr. Joe Spidell. Next. So our intervention, as I mentioned, was designed to avoid contamination among the providers. We had 40 sites across red states and blue across the whole United States. These sites were serving in total about 150,000 contraceptive patients. The intervention was conducted as a half-day training with the full clinic. We went and we delivered an educational intervention, and so unlike a lot of the other work that was going on in some of the observational trials, we maintain usual costs for contraception in our trial. And that's important because as I said, it had a national span and was across states that had really different policies toward contraception. So this way it was going to reflect, was a little risky because it was going to reflect some of these very restrictive policies in states across the country. On the other hand, if it was successful, it meant that it could be scaled across these more, well, not necessarily that, or more adverse state contexts for health insurance and contraceptive funding and reproductive health. We didn't have any counseling scripts or anything that had to be done within the clinic. It was simply delivering education, delivering this course. The participants took what they liked, left the rest. We had a lot of things in place to help them to change attitudes and knowledge and practices, but it was really up to the health centers themselves if they wanted to change a practice in their clinics. So in each of the clinics, we recruited participants, in total 1,500 women ages 18 to 25, not desiring pregnancy in the next year. Next slide, please. And they were all comers also. They weren't people who were just starting contraceptive methods. There were people presenting to the clinic who would have been given contraceptive counseling. The front office desk was really great in telling our research assistants who would have been eligible. And then in a cluster trial, you have to try to enroll everybody, so you don't have a selected sample of people in the clinic or certain days of people who come. So we tried to do kind of mass enrollment at each clinic site. We took about a week or 2 weeks at each clinic site and just tried to enroll anyone who was eligible. And we're pretty successful because we had people on site, and then each health center also helped out with helping to recruit. So I'm sorry about the font here. The color scheme changed in my slides, and if you can't see it, it says, I'll talk just very briefly about the methods. Our primary outcome is so dated now. These, remember, this trial that was published in 2015, but we recruited the women and then followed them out for a year. And so we were designing this, and we launched the trial in 2011, designing it in 2009, 2010. And our outcome was selection of an IUD or implant at the clinic visit. And now our field has really changed and gotten into much better metrics from the patient's perspective of what they would want from a contraceptive visit. And this would not be the primary outcome, but it was at the time. We used methods for cluster data to analyze that primary outcome. Our secondary outcome was pregnancy within 12 months. All the participants took pregnancy tests at 6 months and 12 months. We had medical records review as well as survey data on pregnancy. We used survival analysis and had to use an approach with shared frailty to account for the clustering. There are a couple other analytic approaches that can be used as well, but this is the one that we used in our trial. We used intention to treat analysis with a primary outcome on all 1,500 participants, and on the secondary outcome modified for those who contributed follow-up data, which was more than 85% of them, over 1,300 participants. A little side note, in a cluster trial, it's really important to adjust for covariates, unlike in the individualized randomized trial, because the clusters can become kind of unbalanced, and even if you have similar indicators, measures at baseline, you always want to run models. You can do a model just with ARM, and then you also always run a model with covariates. Okay, thank you. Next slide. So here are the results, and they're kind of in tiny print. They came out of the article itself, and the primary outcome of it, this is the data from patients. The intervention was on the provider clinic level, and then the data we're presenting here is on the patients. So we saw that patients were significantly more likely to select a LARC method, 28% in intervention, 17% in control, in adjusted and unadjusted models. What I don't show here is they also reported on their counseling, whether they were more likely to hear about these methods in counseling. They were, and interestingly, in both intervention and control, they almost universally were likely to hear about more popular methods, the pill, condoms, counseling, whether they heard about those methods or not, weren't affected by the intervention. Okay, going over to the secondary outcome on the right-hand side of the slide, half of our participants were recruited from abortion care clinics. Half of our participants were recruited from more general reproductive health clinics. I have FP here standing for family planning. And for our pregnancy outcome, we did not see overall with the secondary outcome an impact on pregnancy. When we looked at moderation effect, the interactive effect, how the or stratified analyses, how the intervention worked in these family planning settings versus the abortion care setting, we found that in the general family planning clinic, that women who attended clinics, their pregnancy risks were cut in almost half, 7.9 versus 15 in control per 100 person years over the year following their clinic visit. Whereas in abortion care, actually in intervention, it was slightly higher, the pregnancy rate, 26.5 versus 22.3, but there was no significant difference. Basically, statistically, it was similar in abortion care settings over the year. So next slide, please. What was happening post-abortion? Why were experiences with contraception different in the impact of our intervention on pregnancy? Why did it differ by clinic setting? There's several reasons I think it would differ, and one primary one being that women presenting in the abortion care setting obviously are fertile. They have proven fertility. They also have a series of characteristics that differ slightly than the general population presenting at reproductive health clinics, but there was something else going on that's very particular to the United States and our policies and the way that we offer care to women at abortion sites compared to general reproductive health sites. My colleague, Dr. Kareem Raka, did two really great analyses that were published in AJOG looking at sub-analyses, which is something you can do in randomized trials. It's really interesting afterwards to see some of these findings, to really look at what was happening here. And we conducted sub-analyses of the participants recruited at the abortion care sites. And what we found, not surprisingly, were that funding policies in the United States, throughout the United States, had a really high impact on whether participants who had selected to use an IUD or an implant actually obtained that method and used it in the abortion care setting. So our data showed that few participants, fewer than half who chose an IUD implant after abortion, actually obtained their selected method, 44%, and in family planning visits, 73% of the women did. So the second bullet that says, yeah, actual method initiation was really determined by insurance and funding programs. Interestingly, it's insurance and funding programs about abortion too, not just contraception, that really affect people's preventative care, their contraceptive care in the abortion care setting is both contraceptive policies and abortion policies really affect the methods that they walk out with. So what we found is that people who had public health insurance were more likely to initiate an IUD or an implant who had selected it. People who had abortion coverage through state Medicaid programs, they were more likely to be able to initiate their selected method. Not surprisingly, people in states where there were state mandates for private insurance to cover contraception, those work to help people to be able to use the IUD and implant if they wanted, that's with their high upfront costs. And then those people who, there are not so many of them, but those who are able to use their private insurance for their abortion procedure are more likely to select the IUD or implant. And this is not surprising. I think everyone walking into the abortion care setting, they have limited money in their pocketbook and what they can afford. If their abortion isn't covered, then they're just much less likely to be able to afford an IUD or implant. So 38% of the participants in our trial reported that they had no insurance, and this really is, they had a hard time affording an IUD or implant. Okay, next slide, please.
Cynthia, I hate to interrupt, but we need to get close to wrapping up. You're part of the talk.
Okay, thanks. Next slide. This whole idea of IUDs and abortion brings up reproductive autonomy and contraceptive decision-making, which is so important. Back when we did this trial, we had a simple item. We looked to see whether our intervention ended up swaying patients more than in the control clinics. In some, what we found is Planned Parenthood, it seems to do a great job from the participant perspective, with almost 80% in both arms saying they chose the method alone, 14% in both arms saying they chose with the provider. We just got exact results with both arms, which was pretty surprising. 7% in both said they chose no method, and fewer than 1% the provider chose. Next slide, please. Okay, this I'll be very brief. We then took our intervention to scale across the country. This is a map where we have trained, adapting our curriculum over time into different practice settings. Next slide, please. We continue to evaluate our impact in primary care settings and school-based health centers. And we also have adapted our curriculum, looking more at all methods and including a lot of content with reflecting reproductive justice principles. And we are still finding very similar results in clinical practice change as we found in our randomized trial. Next slide. This is, we are now doing a cluster trial in community colleges in California and Texas with UT Austin. Some of the lessons we have learned are that community engagement is so important. We did in-depth interviews here, a huge series, but now we have a very vigorous community engagement component, which is really helping our research and our trial. We're using new metrics, looking at use of preferred method, that our colleagues at UT Austin have been looking at some of these new metrics that are great, and some rigorous psychometric measures to look at pregnancy decision-making and autonomy in these things. And most importantly, right now, we're looking at the experiences of young people during the COVID-19 pandemic. Next slide, please. Okay, and thank you so much. If anyone has any questions about cluster trials or pitfalls or things that we learned, please feel free to contact me. And so many thanks to our many research partners and our training teams, our participants, and our funder of the cluster trial with the Hewlett Foundation. Thank you.
Thank you very much, Cynthia, and we greatly appreciate your time. For everybody that's listening, we are going to have a question and answer session at the end of each part of the symposium. Please use the chat box if you have any questions. You can put your questions in at any time, and we're monitoring those questions, and we'll make sure that they get asked to the speakers during our that part of the session. I'm going to pivot now to introduce David Hubacher, who's also a member of the IUD Symposium Organizing Committee. I recognized Anita earlier. I should also recognize David. David is an epidemiologist at FHI 360 in Durham, North Carolina, and I'll just leave the floor to David. Go right ahead.
Thank you, Mitch. And thank you, Cynthia, for that presentation. You know, Cynthia produced level 1 evidence that was at the facility level. And today I'll be sharing level 1 evidence that is really focused on the technology level. How do contraceptive technologies vary in terms of women's acceptability, satisfaction, voluntary continued use, and prevention of unintended pregnancy. Shown here in this first slide is the 2018 publication for this past project. Next slide, please. And here are the additional publications on this study. Next slide. The initial funding for this project was from NICHD. The extension was funded by Bayer Healthcare, product donations from Bayer, Teva, and Merck. I have served on advisory boards in the past. Next slide. So for today, I'll spend a fair amount of time on the background and rationale for this work. The study details have been published previously, so I'll really focus on the main messages from this project. Next slide. I will be using these acronyms quite a bit. The first is SARC, that is short-acting reversible contraception. And in this study is limited to oral contraceptives and DMPA, the injectable. And also, of course, LARC is long-acting reversible contraception, IUDs, and implants. Next slide, please. Okay, consider these questions. Who uses LARC? Are LARC users disproportionately represented by people for whom an unintended pregnancy would be personally disastrous? Did they choose a highly effective LARC for that reason? Once users start on LARC, is it easier for them to overlook the side effects and report unusually high satisfaction because of their personal needs? Who chooses short-acting methods? Are they disproportionately more ambivalent about pregnancy or just have short-term horizons for use? When you think about James Trussell's effectiveness estimates, are the results biased? Can you isolate the role of technology in measures of effectiveness? Next slide, please. So to better illustrate these issues, let's show attitudes toward long-acting reversible contraception on a continuum. So for example, on the far left side would be those who would never use LARC in a million years. And on the extreme far right, those who claim that LARC is the best. Next slide. Most measures of contraceptive effectiveness of LARC are based on the population in the circle, obviously people who try it. In contrast, we don't know a lot about how well LARC works for people on the left side. Next slide. So for this project, we had three main questions. Is the high effectiveness of LARC truly attributable to the technology? Can typical SARC users, short-acting users, find LARC methods acceptable? And can trying a short-acting method, can trying a long-acting reversible method scientifically prevent unintended pregnancy better than short-acting methods? Next slide, please. The study I'll describe was conducted at 3 Planned Parenthood facilities in North Carolina from 2011 to 2018. We ran a partially randomized patient preference trial to measure continuation rates, unintended pregnancies, and satisfaction over a 24-month period. And this is the IUD Symposium. It's important to let everyone know that 72% of the LARC users in this study were in fact IUD users. Next slide, please. So for this study in North Carolina, we drew from people on the left side of the continuum. women seeking oral contraceptives or DMPA injectable. We specifically excluded women who were at Planned Parenthood seeking a LARC method. Next slide. We invited women to participate in the study. Those who just wanted their short-acting method joined the observational cohort portion of the study, shown on the left in the blue circle. Those who opted for the randomized trial were assigned to the short-acting or the long-acting arms. Now, once assigned, they chose which product in that category that they wanted to use. Next slide. We used intent to treat principles for data analysis. So, for example, if an IUD user had the product removed 4 months after receiving it and later reported an unintended pregnancy, the IUD was held accountable for that event. Thus, we're really measuring the effectiveness of trying a method, which is a much higher standard than typical use measures that we know that describe effectiveness. Next slide, please. Okay, finally, results. So shown here are continuation rates by cohort. As you see, the randomized LARC group shown in the green line had a much higher continuation rate compared to the observational short-acting users, the blue line, and the randomized short-acting group shown in the red line. Next slide. So let's focus on the randomized trial participants. Think of the space between these continuation rate curves as the differential risk for possible unintended pregnancy. Next slide. Okay, well, what about unintended pregnancies? We had 16 reported unintended pregnancies in the randomized short-acting group and 6 in the randomized long-acting group. The observational cohort had more participants and thus more unintended pregnancies. Next slide. So shown here are the cumulative probabilities of unintended pregnancy. The observational cohort of short-acting users, shown in blue, had the highest rates. Next slide. Now, if you compare the randomized groups only, the short-acting users had higher rates of unintended pregnancy compared to the long-acting randomized group. Next slide. And if you compare the two short-acting groups, so this would be the observational cohort of short-acting users and the randomized SARC group, the lines are much more similar to each other in terms of unintended pregnancy. This finding speaks to the generalizability of results from the randomized population. In other words, the randomized trial participants are fairly representative of a general population of SARC users in terms of unintended pregnancies. Next slide. So what about method satisfaction? The levels of satisfaction on this happiness scale with the method were similar in the three groups, in the range of 70 to 80%. Next slide, please. Well, would women in the randomized LARC group ever use a LARC method again? About 73%, shown on the far right, said yes, they would use LARC again. Now, that was a little bit lower than the 86% of women in the observational cohort of SARC users. Next slide. Now, among the randomized LARC users, we examined whether participants cited negative LARC attributes as reasons for never using LARC previously. And we see here that participants with negative perceptions of LARC at baseline had levels of satisfaction with their LARC method that were similar to those who did not have baseline negative perceptions of LARC. Next slide. Shown here are the LARC results in comparison to other estimates. So there were minor differences with the Choice Project in St. Louis that Tessa Madden spoke about in January, and continuation rates in this trial are similar to James Trussell's estimates of around 80%. Next slide. So in conclusion, LARC was acceptable to about 75% of a typical population of short-acting users. The decision to try LARC provided good protection from unintended pregnancy. The high effectiveness of LARC in the circumstances described in this study show that the technology works for a broad population of users. Potential users of LARC do not need to be total enthusiasts to have a reasonably good experience. Thus, we have fairly strong level 1 evidence that the technology and not the users drive satisfaction and effectiveness. Next slide. In the United States, about 83% of women using reversible methods are using short-acting methods. But first and foremost, for SARC users, they should always use the method that suits them best. Voluntary uptake and trying LARC may be worth it. Next slide. Thank you.
Great. Well, thank you, David, for really a very concise and just excellent presentation. And congratulations on all the work that you and your team have done. We're going to move right now to Paula Bednarik. And this is, again, another randomized trial, which has done a great deal to help inform our practice. Paula is an associate professor of obstetrics and gynecology at Oregon Health and Science University and is currently medical director of Planned Parenthood Columbia Willamette, based in Portland, Oregon. So welcome, Paula. And as a reminder to everybody, please use the chat box to enter any questions that you think of during the talks, and we'll make sure to address them during the question and answer session.
Hi, thanks so much. I don't know if we'll switch over. Yep. I'm not seeing my video, but I'm assuming everyone else can. So thanks so much. I'm pleased to be able to present information about the PAIR trial as part of this session about level 1 evidence. This RCT is more focused at the patient level. Next slide. This study started as my fellowship project. We started brainstorming about it in 2005 and 2006. So sort of as alluded to, a different time when we were thinking about IUDs. At that time, there was a lot of interest in being able to place an IUD immediately after a first or second trimester abortion. And we knew that asking patients to return later was a barrier to care. There had been several observational studies that showed potential benefit with low rates of perforation and infection. However, there was also a concern about cost and whether the expulsion rate could be too high, where the benefits may not outweigh the potential increase in expulsion, especially to public health programs and insurers. So it was both safety and cost concerns that prevented this from becoming standard of care just yet. Next slide. There had only been one randomized trial comparing immediate to delayed IUD insertion following abortion, which was published in 1980. And had used the copper-7 IUD, which was no longer available. There had not been any comparisons using modern T-shaped IUDs. Next slide. So we designed this study as a multi-center prospective randomized trial at 4 family planning fellowship sites in the United States, listed here. The enrollment sites included 3 Planned Parenthood affiliates in Oregon, Pennsylvania, and New Mexico, the Feminist Women's Health Center in Georgia, a hospital-based abortion clinic in Georgia, and academic faculty and resident offices in Oregon and Pennsylvania. The study took place over 20 months in 2007 through the end of 2008. And participants chose either a 52 milligram levonorgestrel IUD, or Mirena, or copper T380A, Paragard. Those were the only 2 IUDs available in the US at the time. Next slide. Our primary outcome was IUD expulsion at 6 months. Secondary outcomes included IUD use at 6 months, request for removal and the reason, request for reinsertion after expulsion or removal, and adverse events, including perforation and infection. Next slide. Subjects were 18 and over, requesting uterine aspiration for induced or spontaneous abortion between 5 and 12 weeks, who also desired intrauterine contraception. All subjects were screened for chlamydia immediately before uterine aspiration, and all subjects received perioperative prophylactic doxycycline. Next slide. Subjects were randomized to either immediate or delayed IUD insertion, which was 2 to 6 weeks later. At the time of aspiration, the randomization occurred at the time of aspiration. An ultrasound was performed at the time of IUD placement. Subjects followed up at 1, 3, and 6 months. The 1-month visit was in person, and an ultrasound was performed to assess the IUD position. Subjects maintained a daily diary that tracked bleeding patterns and cramping. The 3 and 6 month follow-up visits were by phone, where bleeding, cramping, satisfaction, and continued use of the IUD were evaluated with questionnaires. Next slide. So moving to results, the demographics were similar between randomization groups. The average age was about 27 years old. This was the first pregnancy for about 20% of subjects. 60% of subjects were white, and just under 50% had had 1 abortion or more previously. Next slide. A total of 578 subjects were enrolled, 258 in the immediate group and 317 in the delayed group. Close to 80% in each group chose the levonorgestrel IUD and 20% the copper IUD. So you can see that 100% of subjects who were randomized to immediate placement received their IUD, while only 71% were randomized to delayed insertion received their IUD. Next slide. So our primary objective, evaluating expulsion, since that was the biggest concern at the time, especially evaluating cost. This slide shows that expulsion was low in both groups over 6 months. The expulsion rate was 5% in the immediate group and 2.7% in the delayed group, and expulsion rates for interval insertions in the literature ranged from 2 to 5 to 6%. So this expulsion rate included both partial, meaning the IUD was seen in the cervix and it was removed in 13 of these women, and complete, meaning the IUD fell out entirely on its own in 6 women. The majority of expulsions occurred within the first 2 months. You can see that vertical line there at the 2-month mark. Next slide. The frequency, next click. The frequency for requests of IUD removal due to cramping, pain, or bleeding was similar between the 2 groups. Next click. About 50% requested reinsertion of a new IUD after expulsion in the immediate group, which was 7 women, and 12.5% requested reinsertion of a different IUD after requesting removal. No women in the delayed group requested reinsertion of their IUD. Of note, of the 7 subjects who had an expulsion and requested a second IUD, 5 had a second expulsion and 1 requested removal due to cramping. Among the subjects in the delayed group who never received an IUD, the most common contraceptive method was condoms in 32%, followed by no method in 25%. Next click. At 6 months, the IUD was significantly higher in the IUD use was significantly higher in the immediate insertion group than in the delayed insertion group, 92% compared to 76%. Next slide. In the 6 months of follow-up, there were no pregnancies in the immediate group and 5 pregnancies in the delayed group, all among women who never received an IUD. Next slide. So there were no significant differences between groups in the rates of any adverse events. Next click. There were a total of 10 pelvic infections reported, and I apologize, there's a typo here under the pelvic infection line. Of the 19 women whose screening test for chlamydia was positive before uterine aspiration, only 1 woman later received a diagnosis of pelvic infection. She was treated with outpatient oral antibiotics and her IUD was not removed. Next click. 2 women in the immediate insertion group and 3 in the delayed insertion group had an incomplete abortion and required a repeat uterine aspiration procedure. Those women who had IUDs had their IUD removed and they were replaced at their request. And there were no uterine perforations noted throughout the trial. Next slide. In summary, the main findings of the study, let's see, next slide. So in summary, the main findings of the study were that when immediate IUD insertion is offered, it has a low expulsion rate, not inferior to that with delayed insertion. It leads to higher rates of IUD insertion, leads to higher rates of IUD use at 6 months, and is not associated with an increased rate of complications. Next slide. There were several sub-studies that we nested into this trial. So next I'll present from one of those sub-studies focusing on bleeding and cramping after IUD placement. Next slide. So these graphs show spotting and bleeding patterns reported through daily diaries during the first month after aspiration among those who chose the Mirena. The left is for immediate insertion and the right is for delayed. You can see there's more spotting than bleeding, and it decreases over time. Next slide. Here we see the same graphs for the copper IUD. There's a slightly smaller proportion of spotting compared to bleeding. Next slide. And when you overlay the combination of bleeding and spotting reported with immediate and delayed insertion by IUD type, the overall report of some type of bleeding is slightly increased during about the first 3 weeks, after which they're very similar. Data from the questionnaires at 3 and 6 months showed patterns of bleeding and spotting of both IUD types as expected based on interval insertion data. Next slide. And this slide shows cramping during the first month post-aspiration that required pain medicine, most commonly ibuprofen. So it's cramping that required pain medicine, not just cramping that patients reported where they didn't choose to use any kind of pain medicine. Cramping that required pain medication is slightly increased during the 14 days following immediate IUD insertion for both IUD types, but then no different thereafter. Next slide. And lastly, I'll present data from another sub-study focused on ultrasound evaluation of IUD position. Next slide. Each subject had an IUD to fundal distance measured at the time of placement and again at their 1-month follow-up visit. We were interested in if this measurement could predict expulsion. Next slide. In the left plot, we see the difference between these measurements that were taken at the time of IUD placement are similar between immediate on the left versus delayed insertion on the right. And in the right plot, we see that the difference is even smaller at the 1-month follow-up visit. Next slide. Looking at the plot on the left, there's small but not significant difference in IUD to fundal distance for those who did not have an expulsion on the left compared to those who did have an expulsion on the right. And looking at the plot on the right for measurements at 1 month after insertion, the median IUD to fundal distance was almost the same between those who did and did not have expulsion at that visit. 5 IUDs were seen in the cervix on ultrasound or were palpable or visible on exam and were removed at the 1-month follow-up visit, and 5 expulsions occurred after this visit. So in conclusion, IUD to fundal distance is not useful to predict expulsion reliably either at the time of insertion or 1 month after insertion. The next slide. I'd like to thank all my co-investigators and all the staff and participants. This RCT was able to collect data that validated the observational studies that preceded it. And as we all know, our practice has changed significantly, and it's now totally routine to offer IUD placement immediately after both first and second trimester abortion care. It was really important that we were able to publish this study in a journal that had reached beyond our specific reproductive health community. And it did take some advocacy to make that happen, to go beyond the OB-GYN literature, to help prompt the policy changes, as we've talked about, that are so critical to create the access that are needed by many patients. So thanks, I'll stop there and turn it over to questions.
Great. Well, thank you all for these magnificent presentations. And we already have some questions. I'm going to try to limit this to no more than about 10 minutes so we can let the other speakers start. Paula, there are a couple of questions for you that centered on perioperative antibiotics, especially since we're placing IUDs. The questions really stem around, were the antibiotics standard or just linked to the IUD insertion itself, and what do you recommend?
The IUD, the antibiotic use was standard at the time of aspiration. So, and that's sort of that's still standard of care. So the type of antibiotic might be used differently, but that was at the time of aspiration. So to be clear, we didn't give antibiotics at the time of IUD placement for delayed insertion. That was just a standard interval insertion without antibiotics. So the antibiotics were specifically given at the time of uterine aspiration, and everyone received a preventive dose.
Great, thank you. And that the ultrasound, just for clarity, were just done for the purposes of the study and not something you would recommend as routine. Is that correct?
Exactly. We were looking at that. That was a big question. At this time, again, it was sort of, as we've all sort of mentioned, this was a really different time when we were thinking about IUDs than we think about now. And so at the time, there was a really big concern that expulsion rate was going to be really high and make this an untenable option for patients. And so we wanted to understand what other information we could gather that could help us understand the potential expulsion rate. And so ultrasound guidance, and obviously ultrasounds are generally available, and we all probably still I certainly use ultrasounds to evaluate IUD placement when patients have complaints or questions. So that was one of our questions at the time was, if we did an ultrasound, could that predict the expulsion risk? And we showed that it did not. So there may be other uses of ultrasound, specifically in follow-up if people may be having symptoms. But in terms of predicting expulsion risk, it's definitely not something we would recommend or that we do routinely, and that IUDs certainly don't need to be placed under ultrasound guidance and things like that. It's not a routine recommendation.
Great, thanks. And we may come back to you. David, I had a question for you. You did a lot of comparisons between the SARC and LARC group and those who were who chose their method versus who were willing to be who were randomized. And I think a lot of these kind of trials, first of all, are incredibly informative, but also speak a lot about the population you're studying, because these women, the women in the randomized group, didn't necessarily reflect the general population. These were people who were willing to be randomized, right? So did you ask why they were willing to be randomized? Because again, there were some people who said yes, and some people who said, no, I just want to pick my method.
Yes, yes, we did. Yeah, that's an important point. So, people choose to join a randomized trial for lots of different reasons. And most of them, the research shows that most people join randomized trials because it provides a personal benefit to them. And in this case, the benefit that we offered was free contraception for 1 year for short-acting users, and of course the free LARC method and removal and everything like that. And so we did ask participants in the randomized trial what was their motivation for joining. And of course, about 60% said it was because they wanted a free method. And most of them didn't care which product it was. They just wanted a free method.
So there could be some issues around generalizability, right? Which gets back to Cynthia's study, where they didn't change the payer part of the study. So it's very interesting how you could see that potential influence. And Cynthia, did your group look more at the abortion population? You mentioned that there was a difference between uptake in the abortion population versus the family planning population, which seemed to be centered around insurance and availability. Are you able, within your cohort, or did you already, or are you able to break down even that abortion population further and look at those who were treated in states where there were fewer restrictions versus those who were more? For example, myself, having been practicing both in Pennsylvania and in California, the availability from a insurance coverage standpoint through medical assistance programs of contraception post-abortion is very different in the states. So are you able to break down that abortion cohort more?
Yes, that was one of the slides where I was taking time unprompted, but what we saw there was that the state policies were significant of whether women actually were able to initiate an IUD or implant in abortion care. And I just think it's really important for everyone to know that these state policies enable preventive care at the abortion site. And I think we get so embedded in these controversies about abortion that some of these lessons about how to provide contraception best in the funding programs just are really wrapped up in that. And you know, maybe now under this administration we can address that. One other thing we saw, and that was a slide that I quickly skipped over, super interesting and not surprising, after medication abortion, which is much more prevalent and important now during COVID-19. IUD initiation was very low, 11 per 100 person years compared to 22 or 20 per 100 person years after aspiration abortion. So if we're giving patients having medication abortions a wide array of choices of contraception, we have to think about, we have to really think about providing them with that care. So.
Great. And then one last question, and then we'll move over to the other group. Is Paula, this will get back to you. Was the uterus sounded prior to IUD insertion? And just so that people understand the process.
Yeah, that was a big discussion point, a debate, and it's still part of training. It's a really critical piece of training when we place immediate post-abortion IUDs, where we don't use the traditional uterine sound routinely, but we do measure the uterus in some way to assess where the IUD should be placed. Often we'll use either, and many different clinicians use different techniques, but usually it's something not quite as small and potentially pokey as the uterine sound. So either the cannula or the IUD inserter itself is a very common practice now, to just use the IUD inserter itself up to the fundus and then move back as placing the IUD. Or I said the cannula, a dilator, different things like that.
I seem to remember during the study, though, actually sounding the uterus. And maybe
not with the sound, though. We did measure it, but we didn't use the uterine sound. That was sort of our big discussion. Yeah.
So we really don't know.
Measure.
Right. But we did measure, and I think that helps translate to the idea that with measurements, IUD or post-placement ultrasound didn't make a difference, right? So it's kind of in that context.
And I will say in this study, the placements were under ultrasound guidance, which I think is now often very commonly done, but we didn't do these placements under ultrasound guidance routinely.
Great. All right, and everybody has different practices, and it would be great to even have another hour on how everybody differs in what they do. But we're going to turn it over to Dr. Long to begin the next session. Thank you, everyone, for your great questions. If there are other questions, please go ahead and continue to use the chat box as our presenters will try to address anything afterwards. So again, congratulations on these great presentations, and we'll move forward. So I'll introduce Dr. Jill Long next.
Thanks, Mitch. Thank you so much to our first three speakers. I'm Dr. Jill Long. I'm going to be moderating the second half of the forum. The next three speakers are going to talk about expansive applications for IUDs. We're going to start with Dr. Anita Nelson, and she'll be talking about IUDs in the treatment of heavy menstrual bleeding.
Thank you so much, Jill. This seems so silly to be talking about this, since this is such in our DNA right now, that this is such an important and well documented benefit. But I think it is important to understand how important this indication was for the acceptance of IUDs in this country after the dismal failures that we'd had earlier. Next slide, please. So we do want to talk about the importance of this health benefit. We want to talk about the ability, how mild does the 52 milligram IUD help us from heavy menstrual bleeding from various etiologies, and talk about how it impacts on heavy menstrual bleeding in some special populations that were not included in earlier studies, and then talk about some newer applications that might be related to bleeding. Next slide, please. I think it is important for us to remember some of the things that David told us earlier on with the first presentation, that if we go back to 1986, about 98% of all IUDs were gone from the market in the wake of the Dowcon-Shields infertility infection issues. In 1988, when Paragard came creeping back very hesitantly. It was approved. It came in with an extensive list of contraindications that really left us very few candidates. In fact, David Grimes, in one of his absolutely quotable times, said if you looked at all of the contraindications and the preferred patient profile, the only people in the United States who would qualify for IUDs were Paris nuns, which wasn't very far from the truth. So that by the time we got around to the time for the introduction of this hormonal IUD in the United States, less than 1% of contracepting women in the United States relied on intrauterine devices. So the next year, the LNG IUS, 52 milligrams of LNG was introduced. Next slide, please. And now let's shift, if we can, briefly. I know this is all very well known to you, that heavy menstrual bleeding is a very common gynecologic problem, that at some time during her life, about 30% of women will experience heavy menstrual bleeding, and it certainly negatively affects quality of life. We know that it impacts younger women, it impacts on absenteeism, it impacts on presenteeism. And it's interesting, of the women who called in sick due to menstrual symptoms, only 1 in 5 mentioned that was the cause of their problem. This is kind of new insights. We have the coal data showing us the economic impacts also. Next, please. I just wanted to share from our own experiences. This is not just, oh, I feel bad, but we definitely know that chronic heavy menstrual bleeding can lead to very serious anemia. At our own institution, Harbor UCLA, we went back and looked at how many women had been admitted to the hospital with hemoglobins of less than 5, just due not to acute bleeding, but chronic heavy menstrual bleeding. And we found 148 women who were admitted 168 times during that very short time period. And look at the ranges of their hemoglobins. The lowest we had was 1.6. She was feeling a little weak, okay? And of course, it went up to 5. Amazing what we found, how very low the patients got their hemoglobin without really thinking it was a problem. Some were referred in because they'd gotten standard CBCs, and people freaked out because the hemoglobin was 3.2. Next, please. The definitions have expanded over time. We had the classic measurements that seem to link a menstrual loss of greater than 80 mLs to anemia. But we've now expanded, because of the recognized adverse impacts on quality of life, to the statement that menstrual bleeding is heavy when the woman says it's heavy, because it's impacting negatively on her life. Now, we may not do a full workup if she doesn't seem to have excessive loss on any sort of objective measures, but we certainly will respond to her need for therapy. So I think that this broader definition encompasses both the ones that we have, the textbook definitions. Certainly any deviation from her own established pattern can be there, and then anything that adversely impacts on quality of life. All very important components. Next slide, please. And I love going back to the original study that linked heavy menstrual bleeding to women's perceptions of their bleeding. And today, with the latest FIGO, we do ask women to rate, how heavy do you think your flow is? And she checks heavy, moderate, or light. And I just want to show you that in populations where there is objective measurement demonstrating excessive, unhealthy amounts of blood loss, that only about 50% of those women recognize that their bleeding is heavy. So we definitely want to query women when we find out that their duration is long, or just standardly ask how many products, whatever it is we can do to try to unmask this unhealthy amount of bleeding that women are having, and maybe thinking that they're more fertile, or they think that it's part of being a woman. Everybody in their family has this. Please, we need to really focus on this problem and help women understand that it may be normal for them, but it's not healthy. Next, please. So there were data at the time of the approval in the United States for contraception, studies from Europe demonstrated clearly that the LNG IUS would be effective. And we can see here a very rapid drop off. The older data from Anderson and the groups using the European population. Next, please. But I'll tell you, as I was there with the launch of this IUD also, when there was 1% of the population using IUDs at the time, bringing in a hormonal method did not impress the insurers. And when we dragged out the European data and said this is very helpful, it can treat heavy menstrual bleeding. We had good objective data for this. They said, nope, until you can demonstrate in this country and get the indication for idiopathic heavy menstrual bleeding, we won't even consider covering it because there's not that great a need. So clearly this study was very pivotal. Fortunately, folks in practice kind of jumped us a little bit and started using it a little bit more frequently for heavy menstrual bleeding, but while we were doing this study. But this was important. And a couple of features to notice here. Notice it was idiopathic heavy menstrual bleeding that was studied. It had the proper design, multi-center, open label, randomized studies across the world, but very heavily focused in the United States. And the women had to demonstrate consistent cycle by cycle loss of more than 80 mLs. And they got a huge workup to make sure there was no other attributable cause for this. If they had small fibroids, less than 4 centimeters, that did not extend into the uterine cavity or distorted that extensively, then they would be allowed into the study. It had to be randomized to another treatment arm. And even though MPA was not approved for the treatment of heavy menstrual bleeding, it was the closest thing that the FDA could find as a comparator. And we were very afraid that in luteal phase, MPA might increase menstrual loss, but fortunately, the women were not put into that position. And had they randomized to MPA and experienced that as a problem, they were allowed to withdraw and switch, but we didn't see that switching. Next, please. So these are, again, the results that you can see did have a significant amount. This is median menstrual blood loss. And when the women randomized to MPA or to the LNG IUS, again, very rapid decrease, normalization. Next month, I wish I'd shown the 1 month data. We saw a huge decline. So very rapid therapy, and it persisted. The blood loss continued to decrease. There was some marginal benefit to the MPA, but nothing that came at all close to what you'd like to have. Next, please. And the proportion of subjects that met all of the 8 criteria that we established to define a successful therapy, and there are 2 of them that were there, were met. And it's important to notice that if a patient came in, and we did have one who started with 400 mLs and she dropped down to about 100, but that didn't meet the less than 80. So she was considered a failure. She didn't think it was a failure, but pretty impressive altogether. Next, please. Now, I do want to say that this is not just the original IUD. These are the same. This is the recent publication of the data of self-reported heavy menstrual bleeding from the other LNG IUS that we have available to us in the United States and growingly around the world also. Next slide, please. Now, if we look to see the amenorrhea rates, since that is considered often quite a coup in the context of heavy menstrual bleeding, we can see that amenorrhea rates, at least in the short term, are really inversely related to the self-reported baseline bleeding. Much more likely in women who come in with lighter bleeding, much less likely with heavier bleeding. Less likely among African-American women. But one very pivotal study was, particularly if you're dealing with someone who has heavy menstrual bleeding, and she's gotten to the 5th year satisfied with with her, or now 6th or 7th year, but this was at the end of the 5th year, and the IUD needed to be changed. It was demonstrated very clearly that when you remove the one IUD and place the second one, that there was no interruption in protection. And in fact, the rates of amenorrhea continued to increase just where they left off, and increased even more during the duration of the second IUD use. Next, please. Well, I said that amenorrhea is often considered a success with the LNG-IUS, but we all know that many women do not tolerate the amenorrhea. It's very problematic. In some studies, nobody preferred it, and up to 65% of women in other studies preferred it. And some of the women who are worried about it, obviously clinicians know this, that the woman is afraid, I won't know if I get pregnant, right? Or that the monthly menses is normal and it reassures her I'm still fertile, right? I'm not menopausal. Interestingly enough, for some of these other perceptions, that it's perceived as a buildup of dirty or blocked blood. I think we've all heard this, but this blocked blood now is being blamed for causing blood clots. It's being caused as a cause for fibroids, for her moodiness, her weight gain, her infertility, or even death. They're afraid that this will cause them to die. If a woman doesn't bleed, then she can be more sexually active. She doesn't have that period off during the bleeding necessarily, and this is interpreted as being promiscuous, and women can be socially ostracized for this. So you need to get into the culture, understand how all of these factors impact onto the woman, and really help prepare her, see if she would be able to tolerate the amenorrhea. And I think that this is important to understand that the reduction in menstrual blood loss may not relate directly to the satisfaction scores that women got. So it was important to study when women use the LNG-IUS to treat heavy menstrual bleeding, what were the satisfaction scores? Next study, slide please. And we can see here, this was a very classic study Gupta did in New England Journal, where they compared mean satisfaction scores with both the LNG-IUS and whatever usual medical treatment was at the time. And we can see there was not a large attrition of the population over time, and the differential maintained, in fact, grew a little bit over time also. So much higher satisfaction scores for its use in the treatment of heavy menstrual bleeding. Next, please. So the next issue was, what about fibroids? Can we use it to decrease the heavy menstrual bleeding with fibroids? So the first question would be, if we can place the IUD and it didn't distort the corset, did it reduce the efficacy? And the studies show it did not. We can see in some studies, PBAC scores did decrease at 12 months and hemoglobin levels rose, and there was no change, however, at all in uterine volume. There was another study where expulsions were higher, and percent of the women required surgery by 12 months, but of the 19 who completed, saw a significant decrease in PBAC scores, but it wasn't sufficient to decrease arrest the drop in hemoglobin. It slowed it down, but it wasn't quite as curative as we might have predicted, but still eligible, still helpful. The data on that are not as robust as it is for the idiopathic. Next, please. The big one that has come out, though, is around adenomyosis and heavy menstrual bleeding. I think that menstrual suppression with the LNG-IUS for women with endometriosis is an important thing to mention because of the dysmenorrhea as well as the blood loss. And where we've seen strong data are that after surgery, that it helps prevent the return of the development of endometriosis. As primary care is being used quite extensively, and for the heavy menstrual bleeding is more effective than it is for the dysmenorrhea, particularly with distal implants. Adenomyosis, though, is very important, and it has the LNG-IUS has been used alone, and it reduced pain, blood loss, and pain. It's been used following low-dose GnRH. It's been used where there have been severe adenomyosis or maybe an adenomyoma where they do the H incision and together followed by the LNG-IUS. It's been used, found to reduce aromatase activity and also COX-2 expression, particularly if there had been removal of the larger adenomyosis implants. And the conclusion today is that the effect may depend upon the type of adenomyosis that she has. And now that we can see those a lot more clearly on ultrasound, we have some more guidance that we can offer patients. Next, please.
Dr. Nelson, sorry to interrupt. Just want to remind you you've got a couple more minutes for your talk.
Thank you so much. And this is the last extension that we wanted to talk about, and that is that quite some years ago, it was shown to be the more effective method to treat endometrial hyperplasia, even with atypia. There was early work on this, but it was clearly whether the regimen was 6 months of oral progestins, we saw complete resolution, almost complete resolution with simple and in the older categorization, complex and atypical. Next slide, please. And just to show us atypical endometrial hyperplasia, now the EINs, median follow-up of 33 months, significant amounts of utility when it was combined with a DNC or agonists or multiple Ds and Cs over time. So these were followed conservatively, and we can see what a tremendous benefit this was. And certainly it was lower when the LNG-IUS was maintained in place. So this is still experimental, but just an awful lot of really hopeful therapy there. Next, please. Next group would be to look at folks who else can be used. We talked about different medical problems. Adolescents with developmental disabilities have been found to be very good candidates with low removal rates due to pain or bleeding, but this generally does classically involve placement under general anesthesia, although newer studies say that may not be necessary. In another study, it was a close second to DMPA for this population. Next, please. And other special groups tested in higher BMIs, in teens with bleeding disorders. Maybe we don't need to reverse them. That's kind of interesting. And I thought this was kind of interesting for menstrual suppression for our female astronauts, our soldiers, and of course, very importantly, transmasculine and non-binary teens. Very important to help them maintain amenorrhea. Next, please. So we have cost effectiveness in comparison to hysterectomy. We have great studies that have long follow-ups that show that even for up to 10 years, if you start with an LNG-IUS, you can reduce the overall costs and reduce, very importantly, unnecessary surgeries. Next, please. So there are certainly some excellent studies about the savings with expanded use of the LNG. And I thought this was kind of interesting. For every 100 LNG-IUS is placed, it's about 31 fewer hysterectomies or 45 fewer endometrial ablations. Next, please. So to summarize, we know these data are there. They not only have come from plethora of studies around the world, but they've also withstood the test of time with the Cochrane reviews. They've been compared to surgery. They've been compared to both conservative surgery and the LNG-IUS have been shown to be safe. They've been found to be acceptable and effective. Comparing progesterone, a later update, most recently in 2020, that the LNG-IUS may improve heavy menstrual bleeding and quality of life compared to any other medical therapy. Is probably similar to endometrial destruction. They're not quite certain about it is versus hysterectomy. Next, please. We have it in authoritative guidelines. Every setting around the world, and I apologize if I didn't include your country, certainly support the use for heavy menstrual bleeding, oftentimes as first-line therapy. So I think we're right here today. Why not just approve it for the treatment of heavy menstrual bleeding, period? Why just have it have a labeling to treat heavy menstrual bleeding in women who want to use IUDs for contraception? I think it's time to revisit this and encourage some support for rallying this point. Thank you so much for your time.
Thank you, Dr. Nelson. That was very informative. I've noted some of the questions in the chat. If you have more, please add them to the chat and we'll try to get to them at the end. Next, we're going to move on to Dr. Lisa Natavio, who will be talking about IUDs and cancer prevention.
Thank you. I would like to start by thanking the organizing committee for the invitation to present today and all of you for joining us. So today I will be presenting data to address the question, do IUDs play a role in cancer prevention? Next slide. By the end of this presentation, I hope you'll be able to review the mechanism of action of the different types of IUDs and how these actions may affect users' risk for cancer. To describe the association between IUD use and endometrial, cervical, and ovarian cancer, I will focus on these aspects of the reproductive system only due to time limitations today, and I hope you will be able to describe the potential role that IUDs may play in cancer prevention. Next. All intrauterine devices induce a steroinflammatory response characterized by marked increase in the number of neutrophils, mononuclear cells, and plasma cells in the tissue and fluid filling the uterine cavity. Next. Copper enhances this inflammatory response, which is toxic to sperm. This enhanced response appears to also extend and affect the entire genital tract, disturbing the physiology of gametes, decreasing the rate of fertilization, and lowering the chances of survival of any embryo that may be formed before it reaches the uterus. Next. Levonorgestrel released from hormonal IUDs, which have historically also included progesterone, causes some systemic effects, but local effects are dominant. In addition to causing the cervical mucus thickening, which prevents the entry of sperm into the uterus, it causes massive decidual changes, atrophic glands, and even atrophy of the entire functional layer of the endometrium. Enzymatic and proliferative activities of this tissue are significantly altered, and any of these actions may alter users' risk for cancer. Next. Let's begin by exploring the effect of the IUD on the endometrium. Next. In 2008, Benning and colleagues published a meta-analysis of literature looking at the IUD use and endometrial cancer risk. 11 articles on 10 studies published from 1966 through April of 2007 were reviewed. Next. And this table shows the pooled odd ratios for IUDs and endometrial cancer among the 10 studies analyzed. An odds ratio estimates the risk ratio with a value of 1 corresponding to no difference in risk. An odds ratio greater than 1 corresponds to an increase, and less than 1 corresponds to decreased risk. Here, the summary odds ratio of 0.54 indicates IUD use was associated with a decrease for endometrial cancer, with a 95% confidence interval of 0.47 to 0.62. This confidence interval does not include 1, which indicates a significant finding. Next. Go back one slide, please. When looking at duration of use, the author saw a 12% reduction in risk for 5 years of use. And this did not achieve statistical significance, but only 5 of 10 studies provided contributing data. Next. Only 3 studies reported on specific types of IUDs used. Thus, data for types of IUDs were too sparse to pool. 8 of the 10 studies had diagnosis date of cancer prior to 1993. So considering the chronology of endometrial hyperplasia and subsequent cancer, it is unlikely that a significant proportion of IUD users in the studies in this analysis would have been exposed to hormonal IUDs at the time prior to when study data was collected. Additionally, not every study controlled for each potential confounder, and not all duration of use measures reported in every study. Next. Here, Felix and colleagues published a pool analysis of the epidemiology of endometrium cancer consortium in 2015. It included 4 cohort and 14 case control studies, in total 8,801 endometrial cancer cases and 15,357 controls. Next. The study-specific odds ratios and 95% confidence interval for endometrial risk associated with ever use of IUDs are displayed in this figure. Towards the bottom of the slide in red, the summary odds ratio of 0.83 and the confidence interval there indicates a decreased risk in endometrial cancer among IUD users. Next. Using multivariable logistic regression, the estimated odd ratio and confidence intervals show a decrease in endometrial cancer risk associated with overuse. When looking at IUD device type, here in red, the inert IUD was associated with the lowest endometrial cancer risk. Next. The red boxes here show a greater reduction in risk with an older age at first use and last use. Next. The red boxes in this slide show the greatest reduction in risk with a duration of at least 10 years and with recent use. Next. While this was a larger study that reported separate results for each type of data, it had similar limitations to the 2008 meta-analysis presented. Next. We still need studies that include a larger number of hormonal IUD users to adequately address the long-term effects of the IUDs primarily in use today. And future studies should describe the biological mechanism. The proposed hypothesis is that the presence of an IUD may induce certain morphological and chemical changes that alter the endometrium and may confer protection against endometrial cancer, possibly by decreasing endometrial proliferation, the decrease in concentration of or uptake by estrogen receptors, and or increase in progesterone receptors. Very few studies have evaluated these direct effects. Interestingly, in one small study of 15 healthy first-time copper IUD users, a decrease in endometrial proliferative activity and decrease in estrogen receptors were seen in endometrial samples taken prior to and at 6 months of use. More studies are certainly needed in this area. Next. Now we'll look at the data on cervical cancer. Next. In this 2017 systematic review and meta-analysis, our group identified 17 studies with individual measures of use of an IUD and incident cervical cancer without recognized sources of systematic error, of which 16 could be harmonized for meta-analysis. Next. Seen here is a forest plot from a random effects meta-analysis of 16 studies stratified by study design and ordered within stratum by year of publication and relative weight of study. Essentially, women who use an IUD experience less cervical cancer, represented by a summary odds ratio of 0.64 and the confidence interval seen in red at the bottom of the slide. Next. However, we were unable to examine further influences of the duration of use, agent placement, and IUD type. They were likely inert and copper IUD users, since most of the studies collected data in countries and at times when the levonorgestrel releasing IUD was not yet available. Next. This next study, published last year by Spotnitz and colleagues, looks at the relative risk of cervical neoplasms among copper and levonorgestrel IUD users identified from 2003 and 2017 in one academic center database. Next. This table shows a number of cases, duration of exposure, case proportions, and rates. From these statistics, the relative risk here in red of cervical neoplasms was lower in copper when compared to levonorgestrel IUD users. Of note, the authors did not compare IUD users to non-users. Next. In summary, ever use of an IUD was associated with lower cervical cancer risk. The risk of high-grade cervical neoplasms may be lower in copper IUD users than hormonal IUD users. And studies are needed to look at the biological mechanism for this protective effect. We know the transformation zone of the cervix is both targeted by HPV and a major inductive site for cell-mediated immunity. One hypothesis is that the tissue underlying the transformation zone is manipulated during IUD insertion and induces a cellular response that might clear persistent HPV infections and pre-invasive lesions. Studies investigating this hypothesis are lacking. Next. This last section of the talk will focus on ovarian cancer. Next. In this 2009 publication, Wheeler and colleagues critically reviewed studies with individual level data on IUD use and cervical cancer diagnosis, of which 11 were used for meta-analysis. Next. This is the forest plot from the meta-analysis evaluating studies by adjusted odds ratio. In red towards the bottom of the slide, women who use an IUD experience less ovarian cancer, represented by a summary adjusted odds ratio of 0.85 and the confidence interval listed below. Next. Similar to some of the meta-analyses presented today, IUD type and duration of use were not able to be evaluated, and the majority of the reports included a history of tubal ligation, which may be a confounding factor. Next. Last year, Balela and colleagues published a similar study and included 9 studies which met their criteria for review. Next. This is the forest plot for the meta-analysis evaluating the 9 studies. They also found a lower risk of ovarian cancer among IUD ever use versus never users with an odds ratio of 0.67. Next. This forest plot includes the studies used in their separate analysis for the levonorgestrel IUD exposure, and the summary odds ratio was 0.58. Next. Although the study did include a separate analysis for levonorgestrel IUD users, it only included 2 studies, and its limitations were similar to the 2019 meta-analysis by Wheeler and colleagues. Studies investigating the biological mechanisms for the lower ovarian cancer risk are lacking. It is hypothesized that it's possible that pH alterations with the copper IUDs and the levonorgestrel IUD anti-estrogenic effects on cell division in the ovary have been implicated in prevention of carcinogenesis. It's also plausible that this immune response may play a role in clearing microscopic cancer cells. Next. So based on observational epidemiological studies, it seems possible that IUDs may help prevent endometrial, cervical, and ovarian cancer. And data regarding the biological mechanisms specific to cancer types are now needed. Thank you.
Thank you so much, Dr. Natalia, for that really expansive review. Again, any questions, please enter them in the chat and we'll try to get to them at the end. Next, but certainly not least, we have Dr. David Turok, who's going to be talking about IUDs and the use for emergency contraception.
Thank you, Jill, and thank you very much to the IUD Symposium Organizing Committee. And I just want to give a special acknowledgement to them. They didn't just do what was easy, though I don't think organizing multiple sessions instead of a single day conference was easy by any stretch of the imagination. And Rachel, thank you for the amazing organizational effort. But the symposium group also didn't just do the easy thing as far as presenting a bunch of science, which is more of what's going on today, but the other sessions really centered people, the people that we serve and who come for contraception and IUD use. And that change, I think, is really significant and to be applauded. So thank you very much for that. And while we're on that topic, I want to lift up an enormous amount of gratitude to all of the people who participated in the Rapid EC study. And they took a chance with this, and we are incredibly appreciative. And like I tell all patients that I discuss some contraceptive study with, this is for us to be able to share with other people so that the information that you generously provide to us can improve care for everyone. And like the very first time that I went to discuss an IUD emergency contraception study at one of our Planned Parenthood affiliates here in Utah, I said, this is so that someday people will say, we want to do it like they do it in Utah and mean it in a good way. And hopefully we're here, we're there now. Okay. So if you're giving a talk that starts on slide number 132 in the slide deck, I think it's just good to cut right to the chase. And that is this is an infographic from our recent publication in the New England Journal that assesses and essentially organizes the entire study results. And what it shows is that we provided and randomized people who were not aware of their group assignment, people who were seeking emergency contraception, and they were randomized to a levonorgestrel 52 milligram IUD or a copper T380 IUD, and there were 317 and 321 participants respectively who provided 1 month outcome data who got those interventions. And the results in the next line are there was one pregnancy in the entire study, and it was among one of the people in the levonorgestrel IUD group. The risk of pregnancy was 0.3%, and the top end of the 95% confidence interval was 1.7. 0 of the copper participants had a pregnancy, and then adverse events were around 5% in both groups. And the conclusion was, in this non-inferiority RCT, that the levonorgestrel IUD was non-inferior to the copper IUD. Okay, for those who are into the science a little more, we'll dive a little deeper. Next slide, please. This study was funded by an R01 grant from the NICHD, and we are incredibly grateful for that. And I do want to say this study will not discuss anything that's FDA approved. So the study objectives. The study was really driven by the fact that we know that from many observational and prospective studies that when people are offered both the levonorgestrel and copper IUD, there's greater preference. More people pick the LNG IUD. And we have fabulous data on the fact that the copper IUD for EC is highly effective. And shout out of gratitude to Kelly Cleland, and I know Norman Goldstuck, I saw, is also on this call for providing us with a superb systematic review on those data. But finally, we did not, prior to this, have any data on using the levonorgestrel IUD alone for emergency contraception. And that is what we sought. So we compared emergency contraception pregnancy risk between the levonorgestrel and copper IUD. Next. And this was, as I had said before, a participant blinded non-inferiority RCT, and I'll discuss the power calculation and inputs for that. Enrollment occurred at 6 Planned Parenthood sites in Utah from August 2016 to December 2019. All of the participants had at least one episode of unprotected intercourse within the last 5 days and desired an IUD and walked into a Planned Parenthood clinic to get their EC. And one quick comment on that, people have asked me since publication, like, how did you get so many people to come into a clinic who wanted an IUD? And the answer is, in Utah, Planned Parenthood has a sliding scale that slides down to 0 for emergency contraception. And even though oral EC is available without a prescription in pharmacies, people know that they can come to these clinics and essentially get it for free. And all of the IUDs in the study were provided at no cost. So participants were randomized 1-to-1 to either the levonorgestrel 52 milligram IUD or copper T380. Next, please. And the inclusion criteria were, we tried to be as broad as possible so that essentially anyone who self-identified as needing EC could get it. And we really limited the exclusion criteria, which you'll see on the next slide. And important to note that every participant had a negative urine pregnancy test as inclusion criteria. Next, please. And the exclusion were essentially things that could reduce the risk of pregnancy and things that were consistent with CDC guidelines and met some of our IRB's desires. Next, please. So the primary outcome was 1 month pregnancy as determined by a urine pregnancy test. And we conducted, this ended up being a modified intention to treat analysis. And we also had a per protocol analysis, which was only included people who were still using the IUD at 1 month. and I'll talk a little bit about the differences in the outcomes. And then we collected data. We tried to make it as simple as possible in order for us to get the 1-month outcome on urine pregnancy test. So we sent a text message reminder the day before the urine pregnancy test was due. And then there was a link to upload the urine pregnancy test photo. We also had a red cap survey that came on the following day to ask about the test results. We also offered people in-person clinic follow-up, and urine pregnancy tests were done then. And then for the 48 participants who did not provide us data in any way among any of those outlets, we reviewed their 1, 3, and 6-month survey data to follow up and conducted an electronic health record review to see if there was any information that said anything about any pregnancy. Next, please. So power and sample size. We did not have good data prior to this to assess what the actual EC pregnancy risk for levonorgestrel IUD users was. And we estimated it at 1% based on a prior study that we did where participants were offered the LNG IUD and oral LNG for EC. The 0.1% for copper IUD users is well established from that systematic review that I previously mentioned. We had 80% power to estimate a 2.5% non-inferiority margin and required 335 participants per arm, and then added 5% for possible variances, which got us to a recruitment goal of 706. Next, please. And the 1-month primary outcome of pregnancy was done by 3 ways. And I'm sorry, I deleted this to simplify this for another audience. So the modified intention to treat, which is the true primary outcome, involved 321 copper and 317 levonorgestrel IUD users. Then there was the per protocol group. And this included anyone who we had 1-month outcome data on. The second group was actually the per protocol group, and that included people who were still using the IUD at 1 month. And then finally, we did a sensitivity analysis that only included those with urine pregnancy test results. So, and that dropped off a few more people. Next, please. So secondary outcomes included IUD continuation, satisfaction based on a 5-point Likert scale, spotting and bleeding data, which was number of days when those were present, cramping and pain, which were assessed on a 0 to 100 visual analog scale, and then adverse events, which were open-ended queries at follow-up appointments. Next, please. So study flow, as I had mentioned before, that people presented to our these 6 participating Planned Parenthood sites. And when it was time for EC, we approached them. So everyone essentially presenting for emergency contraception was offered participation. Next click, please. And that next click included over 10,000 people. Next. And they were all provided with this summary of the study options and how they differed. And there was, at the bottom of the sheet, there was information about desire to participate, and if not, why not? Next, please. So enrollment, next. Sorry, the animated slides don't really work so great in this format, my apologies. So 7% of the people who we approached actually enrolled in the study. And again, yes, this is a low proportion of those approached, but what we were asking for people was to accept an IUD that they couldn't select. And that's a big ask. And we didn't just sort of come up and throw that approach out. We had conducted in that prior study I'd mentioned where we offered people to select an LNG IUD, and they also got oral EC or copper IUD. In that study, we asked people about the willingness to participate in a randomized controlled trial and what would be involved what would make it acceptable for them. And basically it came down to if you said that these were, that there were efficacy of these options and we could change the method at any time, we would be willing to be randomized in a non-disclosed way. So, continue. And then the randomization, we lost 7 people between enrollment and randomization, but randomization split, and it worked. The only difference between the two groups was in the reason that people presented for, there was a 10% difference in the reason that people presented for EC in more people not using a method in the copper group previously. Next, please. And then Rachel, you can hit a couple there. So this is again, from the randomization, there were losses for 8% of participants who did not actually receive the treatment for disclosures or findings that precluded involvement and inability to insert IUDs for 5% of people. And then the 1-month outcome of pregnancy data was available. And this slide is a little bit misleading, and that has a urine pregnancy test. This also included the 48 people who we had to use either survey data only or electronic health record data. So in total, 321 versus 317. Next, please. So the primary outcome by modified intention to treat showed 0.3% pregnancy rate in the LNG group, 1 out of 317 versus 0 in the copper group. Next, please. And then in the sensitivity analysis, where we restricted this just to the people who had urine pregnancy tests available, the pregnancy risk was the same. It was 0.3%. Next, please. In the LNG group. And so this forest plot demonstrates these 3 analyses, the modified intention to treat, including everyone who we had data on, the per protocol, only those still using the IUD at 1 month, and the sensitivity analysis, only those whose results was available by a urine pregnancy test. For all of them, the risk difference between the 2 groups was 0.3%. And in none of these does the 95% confidence interval approach the non-inferiority limit of 2.5%. Next, please. So it works, and it's non-inferior, the LNG IUD. So the secondary outcomes, most notably, are copper. And again, I think these data are interesting in that these are, the participants were masked to the intervention. So that is somewhat unique. And in the copper group, more cramping and sharp pain based on that 0 to 100 VAS scale in the copper group than the LNG group. And then the LNG group had more bleeding and spotting days. And I don't think anyone in this group would be necessarily surprised by that. Continue, please. And then finally, we looked at satisfaction. And I would say that for satisfaction, the worst time to ask IUD users about their satisfaction is at 1 month, which is when these data come from. 84% of the copper and 86% of the LNG IUD users were neutral, satisfied, or very satisfied at 1 month. And that was in response to a question of, please rate your level of satisfaction with the IUD. Next, please. So in conclusion, the LNG 52 milligram IUD is non-inferior to the copper IUD for EC. And I would ask you all, I wouldn't get to ask this to such a fabulous group of people with this kind of insight. To us, there's a part of this that fits into this bigger long-term goal of people being able to walk in and get an IUD at any time when they have a negative urine pregnancy test. And I would ask you, how does this information help you get to that place or help you refute that as an acceptable idea? So thank you very much for the opportunity to present the information, and look forward to some questions. And thank you all for daily showing up for people and providing them with the best care possible and researching new and interesting ways that we can provide people what they want when they want. Thanks.
Thank you so much, Dr. Turek. We've got just a couple minutes left. I'll try to start some of the questions from the chat. One of the first questions is regarding the FDA approval for use of IUDs for heavy menstrual bleeding and lack of insurance coverage. It's a general question to the panelists of how we can maybe overcome that problem. Any thoughts on that?
I don't find that insurance companies are restricting on the basis of indication. I do find coverage for heavy menstrual bleeding, whether she's doing it for contraception first or not. But I think that we do need to find better funding. The funding is actually oftentimes better for the contraception aspect than it is for the heavy menstrual bleeding treatment, right?
Yes, I think that was part of the concern in the comments.
Yeah.
Okay, I'll just, for the sake of time, I'll move on. The question for Dr. Natavi, which I think you touched on, but the question was regarding the endometrial cancer studies, that they were predominantly in copper IUD users versus LNG.
Oh yeah, the more recent meta-analysis, if you look back at the slides, includes a number of cases and controls. The majority of the studies were in inert IUD users.
Okay. For Dr. Nelson, is satisfaction with amenorrhea related to LNG IUS use associated with education level, knowledge, and attitude towards IUD or other factors?
Well, I think that the studies that have been looking at this are really quite diverse. That we found, if you ask what the preferred bleeding pattern is, it's just all over the place. I was looking at one study where 0% of women in Tunisia preferred amenorrhea. In Brazil, they claimed that it was closer to 60% of women preferred amenorrhea. And you try to wrap your hand around it. Younger women in general and older women, but not the women in between. In many countries, very much preferred amenorrhea. But I think the real question to ask ourselves when we're using this is not what's the preferred pattern, but what would be the tolerated pattern. Getting back to what David was talking about with continuation rates, that are we going to make them unhappy using this because we're presenting a bleeding pattern that they just can't tolerate. We want to meet that minimum criteria. It may not be what they're striving for, but certainly it would be, we would want to make sure that they would be able to live with it. And getting to the real core of it, education by itself doesn't mean that you understand reproductive life and trying to understand she understands how her body works and what she believes these different symptoms tell her about how her body's working. And I never give up on education. I think that's what we try to do every day, is to help women understand a little bit better, people understand a little bit better about their body and their health. But I have found, looking through, I didn't see anything in any of the studies where education was higher among the women who appreciated amenorrhea.
Okay, thank you.
Some questions about that, please let me know.
Some questions for Dr. Turek. What's the mechanism of action of the LNG IUS for EC?
Who knows? We could talk forever about potential mechanisms of action, and it is theoretically possible that an exogenous progestogen introduced at a time when egg and sperm are awaiting interaction may alter that ideal interaction. The bottom line of this is we are not going to figure this out. And almost certainly there is some post-fertilization effect. And we should inform people of that. That seems like a good and reasonable thing, because if this is not the right thing for you, if that's a problem for you, then this is not the right method. And at the same time, there's going to be a whole bunch of people, they're coming, who are going to oppose this as an access point, because they don't like the idea that people are having sex and don't want them to be able to control their fertility with methods that work post-fertilization. And for them, fine, don't use it. But don't stand in anyone else's way to get access to the method either, please, because that's not reasonable. So that's my current wrap on that.
Okay.
Could I ask a question? Do you think that the procedure of the placement of the IUD might disrupt things?
I absolutely. I mean, there's potential, right? Yeah, for sure.
Maybe independent of what IUD you're placing.
Right. It seems based on, and there I saw some other data, based on the sort of frequency of episodes of unprotected intercourse that our participants had, over 40% had more than one episode. And then we also asked people what was, we, independent of the clinical care, we gave them a diary to report all of their episodes of unprotected intercourse in the last 14 days. And based on that information and, information on people's cycles, it seems like just an inflammatory reaction from placement might not be sufficient to explain it all.
Good.
And again, like, this would be incredibly difficult to study and get a real answer to.
Thank you. Yeah, Rachel, do we have time for more questions, or do we need to wrap it up at this
I'm
point?
afraid we need to wrap it up, but we can put answers to further questions on the website. So we will do that. Thanks to everyone for participating. And if you want CME credit, you must complete the evaluation, which will be sent out hopefully later today or early tomorrow. And please join us on May 5th for new approaches in IUD provision and public health impact of IUDs and IUSs.